Optic neuritis is a multi-etiological condition consisting in the inflammation of the optic nerve that may cause a complete or partial loss of vision. Causes: the optic nerve comprises axons that emerge from the retina of the eye and carry visual information to the primary visual nuclei, most of which is relayed to the occipital cortex of the brain to be processed into vision. Inflammation of the optic nerve causes loss of vision usually because of the swelling and destruction of the myelin sheath covering the optic nerve. Direct axonal damage may also play a role in nerve destruction in many cases. The most common etiology is multiple sclerosis. Up to 50% of patients with MS will develop an episode of optic neuritis, and 20 to 30% of the time optic neuritis is the presenting sign of MS. The presence of demyelinating white matter lesions on brain MRI at the time of presentation of optic neuritis is the strongest predictor for developing clinically definite MS. Almost half of the patients with optic neuritis have white matter lesions consistent with multiple sclerosis. At 5 years follow-up, the overall risk of developing MS is 30%, with or without MRI lesions. Patients with a normal MRI still develop MS, but at a lower rate compared to those patients with 3 or more MRI lesions. From the other perspective, however, almost half of patients with any demyelinating lesions on MRI at presentation will not have developed MS 10 years later. Some other causes of optic neuritis include infection, autoimmune disorders, inflammatory bowel disease, drug-induced, vasculitis, B12 deficiency and diabetes. Symptoms: major symptoms are sudden loss of vision, sudden blurred or foggy vision, and pain on movement of the affected eye. The vision might also be described as disturbed blackened rather than blurry, as when feeling dizzy. Many patients with optic neuritis may lose some of their color vision in the affected eye, with colors appearing subtly washed out compared to the other eye. A study found that 92.2% of patients experienced pain, which actually preceded the visual loss in 39.5% of cases. However, several case studies in children have demonstrated the absence of pain in more than half of cases in their pediatric study population, with the most common symptom reported simply as blurriness. Other remarkable differences between the presentation of adult optic neuritis as compared to pediatric cases include more often unilateral optic neuritis in adults, while children much predominantly present with bilateral involvement. Symptoms peak several days to weeks after onset, while symptoms failing to improve after 8 weeks should suggest a diagnosis other than optic neuritis. On medical examination, the head of the optic nerve can easily be visualized by a slit lamp with high plus or by using direct ophthalmoscopy. However, frequently there is no abnormal appearance of the nerve head in optic neuritis, though it may be swollen in some patients. In many cases, only one eye is affected and patients may not be aware of the loss of color vision until they are asked to close or cover the healthy eye. Epidemiology: optic neuritis typically affects young adults ranging from 18 to 45 years of age, with a mean age of 30 to 35 years. There is a strong female predominance. The annual incidence is approximately 5/100,000, with a prevalence estimated to be 115/100,000. Treatment and prognosis: in the vast majority of MS-associated optic neuritis, visual function spontaneously improves over the first 2 to 3 months, and there is evidence that corticosteroid treatment does not affect the long-term outcome. However, for optic neuritis that is not MS-associated, the evidence is less clear and therefore the threshold for treatment with intravenous corticosteroids is lower. Intravenous corticosteroids have also been found to reduce the risk of developing MS in the following 2 years in those patients who have MRI lesions. But this effect disappears by the 3rd year of follow-up. Paradoxically, it has been demonstrated that oral administration of corticosteroids in this situation may lead to more recurrent attacks than in non-treated patients. This effect of corticosteroids seems to be limited to optic neuritis and has not been observed in other diseases treated with corticosteroids. A Cochrane systematic review studied the effect of corticosteroids for treating participants suffering from optic neuritis. Treatments reviewed included intravenous methylprednisone, oral methylprednisone, and oral prednisone. all treatments reviewed did not show any benefit in terms of recovery to visual acuity, contrast sensitivity, or visual field. In the longer term, there is evidence that patients with MIS who first present with optic neuritis have a relatively more benign MIS course. In popular culture, in the Season 5 episode of Dr. Quinn, Medicine Woman, Season of Miracles, Reverend Timothy Johnson is struck blind by optic neuritis on Christmas Day, 1872. He remains blind for the duration of the series. See also, optic neuropathy, visual snow, references.